thank you, everyone, and thanks for having me. And, I know that next year I've already been told we're going to get a bigger room, and I apologize. It was just sort of like trying to figure this out. So got to get a better setup, and we will do that next year. But again, as Dr. Axman told you, I mean, it's very important to work as a multidisciplinary team. And I think with Dr. Treppel and all of NYCPM, all the faculty and the fellows and residents, I mean, it's been an incredible experience for our patients. So I'm just going to break it down. And, Dr. Treppel asked me to speak about the diagnostic lab and the role of anatomic and physiologic testing, and really sort of a algorithm for all of you when you see the patients and, maybe what test to order. I know sometimes it can be you wonder what's the best test and what's the test that'll kind of give you the answer that you're looking for, and how do you correlate with that symptom, and I hope this can help. So, again, let me see. So I like starting with stories, and I think this is a good story, presenting to you. So if you have a patient coming with leg pain, and it's often in your practice, I'm sure that you have leg or foot pain when the patient comes in, it's very important to start with a history. And I mean, you need to, I don't have to tell you guys, you teach your fellows and residents all the time about this. What's the history and what are their risk factors for atherosclerosis? And, starting to correlate them is, what is their risk of an atherosclerotic, origin for their pain? So I always say, with the history, if they have a history of CAD, any sort of stenting, any hypertension, COPD, any history of smoking, or any sort of end-stage atherosclerotic event, whether they've had a stroke, whether they're on dialysis, whether they have renal failure, any situation that would tell you that this patient's global burden of atherosclerosis is high has to increase your radar. But this particular patient had a few of those and was complaining really of bilateral cramping, left greater than right when ambulating any distance. The other thing I look at is medications, and when I teach the residents in the school, we talk about medications. What can you get? It's very important to remember that the medications will also give you a clue towards what their problem is. So if they're on antihypertensives, that's fine, but if they're on something like atorvastatin, losartan, you know that these patients have a high cholesterol as well, and sometimes you're able to get more information if they're on antiplatelet therapy as well. The other thing is to look at what the leg pain is. So is the leg pain related to ambulation? Is it related to exertion, or does it just occur anytime? So for this particular patient, leg pain was at night, and it was sometimes. The patient had some numbness, tingling, and radiation from the hip. So this is a complex patient because you've got a patient with all atherosclerotic risk factors, got very atypical leg pain symptoms. Easy to write this patient off as, oh, you've got sciatica. Maybe they do, maybe they don't. This is a patient that warrants at least a deeper look into what you're doing. So what you did in this particular patient, what we did was we said, you know what, let's go ahead and get a duplex. So we got a duplex in this patient for the reason being is that we said, well, why skip the ABI and why get the duplex? We'll talk about that. So when we did this, it said the B mode said the report comes back as 20 to 49% with heterogeneous plaque, no significant stenosis. So this is how you look at and why you get a duplex. When you look at a grayscale, you get the vessel and the plaque morphology, thrombosis, and aneurysm. These are what you can see. The Doppler will help you localize the level of the disease and quantify blood flow, velocity, direction, and stenosis. So when you start looking at a duplex and why we read it this way, as an operator, this is what we're looking at. This is what your report should reflect. So if you get a duplex from a doctor saying no significant stenosis and that's it, they're not really doing much. They're probably signing the text report. But if you get a duplex that says some detail about the vessel, then you know you're getting an actual good duplex that you can make something about. But again, with this duplex, the problem with the duplex is it's an anatomic study. It does not tell you if there's a lesion or if it's causing the patient's symptom or of hemodynamic significance. So what are the indications for the arterial duplex? Well, one is to localize or characterize the lesion in the setting of claudication, okay? So the only time I get a duplex is if I want an anatomic diagnosis. If I'm uncertain about the physiology of the diagnosis, then the duplex is not the right answer. So for the first patient, might not have been the right text. So to go for a duplex is expensive. It's difficult because you have to get a prior authorization. You have to do all sorts of things. Once you've made a convincing diagnosis that this is related to atherosclerosis, then getting a duplex makes sense because now you're saying, okay, well, I want to localize and characterize this. maybe I want to plan on sending it to an interventionalist or a vascular surgeon to go ahead and revascularize. Or as an interventional and vascular surgeon, I may want to do a duplex to evaluate what's the result of what I've done, or if I'm suspecting something else, aneurysms, so on and so forth, which is beyond the scope here. So to break it up, to sort out leg pain, which is very, very complex, there are multiple causes. You have PAD, spinal stenosis, lumbar disc herniation, osteomyelitis, or venous claudication. And this is where the history really plays a role. We have to put back our podiatry medical student hats on. With PAD, it's always exertional, okay? It's reproducible 100% of the time, okay? And it's called intermittent claudication. Generally speaking, it's defined as a symptom located to a group of muscles produced by exertion, relieved by rest. If it does not come on an exertion, well, that's intermittent, then it's really not PAD. But if it's constant in a patient who has no palpable pulses, all the risk factors, then it can become what's called as critical limb ischemia or rest pain. But most patients will present with PAD. The second is spinal stenosis. Again, this is the same thing. You can have the same type of patient with all the risk factors who has exertional or positional rest pain. It's called pseudo-claudication. And they walk, but here it's always bilateral. They get bilateral pain on both sides. It's not sciatica, it's bilateral pain because of narrowing of the lumbar disc. These are the old ladies, when I grew up in Brooklyn, you see them walking with the shopping cart leaning over and walking like this and then stopping and leaning over to relieve the pain that they're having compression in the spine. Lumbar disc herniation, again, worse with exertion, usually an immediate onset of some sort of pain radiating from the buttocks all the way down and lingers after rest. Osteoarthritis, again, it's a differential for everything you guys do. And venous claudication is different because sometimes these venous patients can also present with single leg pain, but it's more of a fullness or a bursting. Usually occurs at the end of the day and not really during early in the morning. So it's a spectrum. And when you look at the spectrum of PAD, is majority of the pain, this is why I talked about podiatry being so important for diagnosis of atherosclerosis. 20% of the patients who have early atherosclerosis are totally asymptomatic from their PAD. But that is the early diagnosis that needs to be made to prevent their cardiovascular outcomes that's already brewing in the heart arteries. Again, atypical leg pain is going to be the majority of these patients that you see, 50%. Only about 30% will be claudicants. And a chronic limb-threatening ischemia generally is less than 10% in the population. Probably podiatry will be much more because they obviously come to you first sometimes rather than come to the ER. So also, what's important to remember is that once they diagnose as chronic limb-threatening ischemia, which is a spectrum of rest pain, gangrene, and/or ulceration, 25% of these patients will require amputation for pain, non-healing wounds, or life-threatening infections. So it's a huge number. And you all know the mortality associated with amputation. I don't have to tell you that. So another little trick is, the rule I teach the fellows is, if the level of the disease is one level above the level of the symptoms. So if the patient is having buttocks claudication, say right buttocks claudication, of course sciatica can be a variant, but generally speaking, if it's on exertion, relieved with rest, then it's probably the one level above the artery supplying the gluteus maximus, which is the internal iliac artery. So it can be the common iliac artery if it's right side, or the internal iliac artery or ostium. If they're having thigh claudication, then obviously it can be the external iliac or the common femoral, and then if you're having calf claudication, it's the SFA. And then if you're having tibial or foot claudication or ulcer, it's going to be that. So it's also important to remember that your patients are presenting with multi-level disease because a lot of the patients you're seeing in your practice are diabetics. Most of the internists, as soon as they see a diabetic, have you seen a podiatrist? Have you seen an ophthalmologist? Have you seen a nephrologist? It's kind of the algorithm they follow. So it's important to remember that a lot of times you might get a patient who's maybe not exerting him or herself, but however, they do have underlying smoldering PAD. So as far as evaluation, how do I break it down? I think simple is to think about functional testing and imaging, and when should you use both. So functional testing is physiologic. PAD, if it's not ulcer or gangrene, is a physiologic a disease. So is there an arterial flow problem, and is the symptoms being caused by that? So what are the tests that I can recommend for you guys? If you're not sure, then you want to do an ankle brachial index or a toe brachial index, okay? If you add pulse volume recordings, Okay, it increases the sensitivity and the specificity of your study. Segmental limb pressures show you a drop in systolic pressure between, say, the high thigh and the mid thigh and the low thigh to help you localize the disease. And of course, continuous wave Dopplers are expensive, usually are not available in anybody's office. It makes sense. But the thing with ABIs is in your office can be done with exercise and rest. And you can do toe raises in your office if you're doing ABIs, or you can make them walk up and down the hallway for a minute and a half, and then do it at rest and exercise and bill as an exercise ABI. So I think that it's very important it depends how deep you want to get into the diagnosis of PAD, it's an important test. Imaging we went over. Imaging is for the assessment of the arterial circulation once you've confirmed that this patient has PAD. I would never do a duplex to say, hey, does this patient have atherosclerotic disease? In my opinion, no. If you want to figure out whether this is a symptom caused by atherosclerosis, you have to do a physiologic test. Anatomic test is to confirm. Once you decide, hey, it's symptom limiting enough or a problem, I'm going to treat this patient, that's when you do this. Obviously, duplex is the cheapest, readily available, but again, I told you, a lot of fake labs around there doing all sorts of nonsense. Important to send it to a good lab that you trust, so you can trust the result. CT, MR, fantastic. However, CT is, again, radiation, contrast. You need to get a creatinine clearance. MR, the same kind of problems. Angiography should be reserved when you decide to treat. When you say, hey, you know what, this patient has XYZ symptoms or have an ulcer, I'm going to treat this patient, send it to the vascular guy or girl to go ahead and have that done. So ABIs, again, just to go over, I know you've seen this millions of times. It's nothing but a pressure, a ratio between the highest ankle systolic pressure of each leg and the highest brachial systolic pressure, right or left. And again, normal is greater than 0.9. Anything less than 0.9 is considered abnormal. Very specific, sensitive, but very specific to the disease. And it's more specific than pulse exam or the Rose questionnaire. So it's very, very powerful test. Second thing, ABI is a marker of mortality. If you have a patient with ABI, you've diagnosed global atherosclerosis, period. So if you have global atherosclerosis, you take a population of 100,000 patients with normal ABIs and 100,000 with abnormal ABIs, the ones with abnormal ABIs will have an early cardiovascular mortality. So automatically, you need to make sure that you are referring the patient for risk factor modification by a cardiologist, internist, doesn't really matter who you send it to, but somebody in your note saying that, hey, this patient is at high risk. It's very, very important. So again, this is just a schematic of an ABI I'm not going to go over. So what are the limitations of the ABI? It doesn't localize the level of the disease because all you're getting is a foot pressure, right? You're not going with the segmentals. There's variability between exams. Blood pressure is higher, blood pressure is lower. And especially in calcification, as the patients you're going to see, and I see so many x-rays from all of you all about calcified arteries in the tibials, you can't compress them. So therefore, you're going to get an elevated ABI. And remember, getting an ABI greater than 1.4 is non-diagnostic but suspicious for atherosclerotic disease. So in those patients, you need to do a TBI. So what do you do again, we talked about this to locate the level of disease. Segmental pressures, variability between the exams is important, but especially if you have a change of greater than 0.15 between the exams, you still should consider it significant because blood pressure will not do that. And then again, we talked about the toe brachial index. It's also very poor in mild disease. So what you need to do is if you do a regular resting ABI and you're like, it's normal, but this patient really has the risk factors and really is having symptoms, make them walk. So some sort of testing to bring out the disease is important. And if you do a exercise and post-exercise, a drop in 30 millimeters for pressure or a decrease in ABI greater than 20% is significant. Maybe falsely normal, we talked about that, and that's it. So these are just segmental leg pressures. You can see the cuffs are available, and you can see any drop in systolic pressure with a change in the waveform from biphasic, triphasic, et cetera, to monophasic really shows that the patient has disease. So again, this is the arterial waveform that we're going to look like. This is the normal one, sharp upstroke plus a dicrotic notch. Again, you start to lose the peak and the loss of the dicrotic notch. Then you get a parvus tardus waveform. And then, of course, when it's severely normal, it's very obvious. So let's go to another patient, 78-year-old patient with leg pain. You can see the resting ABIs are 1.08 and 1.10. And you can see the waveforms are relatively normal. So what you did, what this patient, because of the risk factors, you decide to exercise the patient. So the patient exercised at the treadmill at 2 millimeters an hour, 2 miles an hour at 12% gait, and was terminated due to leg plane left more than right. So this is rest, and this is post. So the patient has PAD, no question, because they had leg pain in exercise, but the pain is not due to the PAD, because they didn't drop their ABIs. So therefore, in this patient, it's an opportunity to optimize their medical therapy and not send them, because physiologically their PAD is not causing their pain. So what is risk factor modification? And I speak to our podiatry students all the time about this. Tobacco, so what decreases the risk of MI, death, and stroke, which is kind of what we all want to do, is save our patients' lives. So in order to do that, you want to just talk to them about stopping tobacco, walking, making sure, and I tell the students all the time, you don't have to prescribe the medications. Ask. There are medications that are known to reduce the cardiovascular morbidity and mortality associated with PAD. ACE inhibitors, statins, antithrombotic therapy. Your job is not to prescribe any of them, and that's what I tell them all the time, but it's important to put it in your note that the patient has the following risk factors and may benefit from pa. We're all physicians, and sometimes the internists and the cardiologists get overwhelmed. They don't think about these things. Important to do those things. So these are the things that reduce stroke and cardiovascular outcomes. But improving the symptoms and preventing amputation, again, tobacco, just stopping tobacco, walking program, cilostazol, of course, good foot care I don't have to talk to you about, and revascularization when symptomatic. So this is the exercise. We talked about this, and it's been proven that it does work. Toe up and heel raises up to 1 second can be an exercise test. So let's take another patient. 69-year-old male with left leg ulcers, history of bilateral occlusive DVT, post-thrombotic syndrome, and left ulcers for 5 months. Non-healing, recently more painful, especially at night. History of CAD, PCI to the LAD in 18, hypertension and hyperlipidemia, and on apixaban, which is a DOAC, atorvastatin, metoprolol, and lisinopril. So you do your ABIs in your office, you get 0.9 here and 1.24. Your TBIs are 0.51 and 1.38, and 0.38, and you could see your waveforms are flat, and your location of your ulcer and the skin changes that are very very suspicious, not of arterial ulcer, but clearly this is a venous ulcer. So distinguished ulcerations, again, you are the experts, but I'll just go for the sake of completeness. Critical limb ischemia is generally like this. This is atheroembolism, and this is venous ulcers, and of course, neurotrophic ulcers. What's important to remember is don't write off your venous ulcers as just venous ulcers. About 26% of patients with venous ulcers have both peripheral arterial disease and venous disease. A lot of times we get patients who have been treated incredibly well by podiatry with wraps and trying to shrink the ulcers, and they do not close. We go ahead and do further evaluation, find that they have mixed disease, we open the artery, and then along with the care of the podiatrist for the venous ulcer, they heal. So very, very important to keep that in mind. So this is important. I'm gonna skip this slide. So what about toe brachial index? So normal is greater than 0.7, and we talked about microcirculation and in diabetics. Used in the setting of vessel non-compressibility, greater than 250 millimeters, or calcification or ABI greater than 1.4, may be used when the ABI is felt to be unreliable, and small vessels are not generally affected by calcification, which is really good. TCPO2 is really advanced, generally not done even at Sinai, we don't do it, but it's very specific in terms of whether the ulcer will heal or not by using the TCPO2 pressure. So again, what imaging to consider? For duplex, very specific, very sensitive, but it's operator dependent, we talked about that. I use it for multi-level stenosis or heavily calcified vessels if I need to. MRI, again, very sensitive, very specific. Again, it's got its issues. To CT, you end up, again, very sensitive, very specific. Again, you have to use contrast, radiation, and heavily calcified vessels are an issue with CT. And then catheter-based angiography only if you're going to intervene. So here's a 70-year-old patient with intermittent claudication. He has reduction in exercise tolerance for the last 6 months due to bilateral calf and thigh claudication to less than 5 blocks. He's a vascular path. He had an MI at age 30, and he's got a kidney transplant. He has a right EIA, was what, internal iliac artery issue, and then diabetes, hypertension, hyperlipidemia. He has a cervical bruit, a periumbilical bruit, and his pulses are intact and normal skin findings. So in this gentleman, we went ahead and did an ABI. Right was 0.9 and left was 1.24. And in this gentleman, we got duplex. So the reason we got duplex is because his symptoms didn't match his ABIs. So I wanted to figure out what's going on. So you can see here, he has a left flank in the common iliac artery. He has a stenosis. And you can see here the peak systolic velocities at 353, suggestive of iliac disease. We went to the catheter-based angiography because now we knew we had a diagnosis. He has a very tight 90% common iliac disease. And then we went ahead and stented it. So, oh, actually, no, this guy, so the doctor actually put him on an exercise treadmill, and then after the stent, everything was fine. So summary and the goals of the PAD, this is what I would say. Does the patient have disease? Okay, physiology equals imaging. So in this case, if you want to just make a diagnosis of just disease, you can do both, but I prefer you do physiology if you have any doubt. Where is the disease located? Imaging always trumps physiology. This is the most important thing. Even if you have blockage, doesn't mean you have symptoms. So does the disease relate to the patient's presentation? Always physiology alone. What are the therapeutic options for this patient? Imaging is greater than physiology. And what are the results of therapy? Physiology alone. Again, I thank you, and I hope that's been helpful. Thank you very much.